Hi, everyone. Welcome to tonight's webinar with our pelvic health physiotherapist, Adriana Spassova. Tonight, we're going to be talking about all things pelvic floor in pregnancy, and I'm really excited to get started. So, Adriana, I will let you take it away.
Thank you. So my name is Adriana Spassova, like Kier said. I've been a physio for about 13 years now, and I've been doing pelvic floor therapy for over 6 years now. I started working at Bosner almost 4 years ago, and my caseload is mainly obviously pre and postpartum there, which I love. So I'm going to get started here with my presentation. Let me just give me 1 second. So again, a little bit about myself. I graduated from Queens in 2012, mainly worked as an orthopedic manual therapist, like I said in the beginning, for about 6 years. And pardon me, then I took all of the pelvic floor courses and then started to treat after starting to work for Bosner, mainly the pregnant pre-postnatal population. I've enjoyed it lots, and the reason I sometimes I get asked why I started to do it is when I was pregnant with my firstborn, I ended up seeing a pelvic floor therapist because my friends were already doing it, and they suggested that I see one for sure, and it was really a game changer for me. It taught me a lot. Even as a physio, I thought I knew how to control my pelvic floor, activate my pelvic floor, but the pelvic floor therapist that I saw, like, just taught me a lot and showed me that I really didn't know as much as I thought I did. And it really helped me through my pregnancy, delivery, and yeah. And then I wanted to kind of share all that info with my patients, and enjoy doing it, especially the birth and labor prep with my patients at the end. So just a little bit about what we'll cover. We'll go through the pelvic floor anatomy, kind of what the pelvic floor is, its functions, what the changes or so yes, what changes happen to the pelvic floor during pregnancy, the common pelvic floor conditions that can happen during pregnancy, and then how a pelvic floor therapist can help. So, with respect to the pelvic floor anatomy, your pelvic floor is made up of 3 different layers. Sorry, my nose is so itchy. The first layer is this picture here on the left. It's made up of 3 muscles. They form a little triangle. They form the first layer of your pelvic floor. Your external, and then there's an internal anal sphincter, forms the second layer of the pelvic floor. And then the third layer are the deep muscles. So they are internal muscles. There is an additional 7 of them. They're also separated into front, middle, and back components. So the front muscles, there's 3 of them. One wraps around the vaginal opening, one around the rectum, one attaches from the pubic bone, near the pubic bone, sorry, to the tailbone. So those are they're considered anterior or front muscles of the third layer. The big red triangle is the middle portion of the third layer. And then there's 3 muscles, pardon me, in yellow and the one in green, and they form what we call the posterior wall. So your pelvic floor muscles all work together and they form what we call a sling. So again, you can see it in this model here. They attach from the pubic bone, they go all the way to your tailbone. So they function as a trampoline and they help support your bladder, your uterus, and your rectum. So the other thing here, so the first one that it stabilizes and controls the pelvis and the spine. Your pelvic floor is part of 4 different muscles or parts that make up your deep core system. So your pelvic floor at the bottom, I think in my other picture, I'll be able to show you guys. There's your diaphragm, which is your main breathing muscle that sits like at the top of the rib cage. Or at the bottom of the rib cage, sorry, at the top. And then there's your deep core muscle called your TA. It starts at the pubic bone, goes all the way up to the rib cage, and it wraps around forming like a corset. And then there's also little muscles called multifidi in the spine here. So again, pelvic floor is one component that helps support the spine and the pelvis, along with those other 3 muscle groups that I mentioned. So if there's any dysfunction in the pelvis, if something's not going, working properly with your diaphragm, if our deep core muscle isn't activating well, or there's a dysfunction there, then it disturbs the way that our pelvis and spine are aligned, and in essence also the way our posture is at that point. It does support the internal organs, like I mentioned, bladder, uterus, rectum. It maintains fecal and urinary continence, so we need those muscles to stay strong, to function properly, to prevent any leakage from urine or fecal matter. They obviously have a sexual function, and they are considered a sump and pump system, so they are constantly working. We'll talk about that, I think, in another slide or two, but they're constantly activating and releasing throughout the day. They're part of what we call the autonomic nervous system. So just like your heart rate, your breathing, you don't have to think of your pelvic, you have to tell your pelvic floor to work. It's doing that all the time. It's pumping in good blood flow to all those muscles. It's getting rid of any other fluids that we don't want in the area. It's getting rid of them and down into also moving it into the lymphatic system. So again, just as I mentioned, it's part of your deep core system. And again, it's your diaphragm here, like I was trying to show on myself at the top. Your pelvic muscles are at the bottom. The transverse abdominis, that deep muscle that forms a corset, again, all the way from the pubic bone to the bottom of that rib cage there. And then these tiny little muscles in your spine called the multifidi. So again, pelvic floor is super important in maintaining that deep core system. Oops, I'm so sorry. What did I do there? Oops. Okay, so like I mentioned, it acts as a sling system, supporting the bladder, the uterus, and the rectum. So it functions as a trampoline. When the pelvic floor muscles are strong and working optimally, they help support those organs. There is no incontinence, there's no leakage happening. When we are pregnant, that sling system softens. There's obviously a lot of relaxin in our body. All your ligaments are lengthening. The pelvis also starts to shift forward because as the belly grows, I think I have that in the next image as well. As the belly grows, it starts to pull that pelvis forward. And as that happens, there's a weakening of your tummy muscles. So the deep core system is definitely affected. As that pelvis is rotated forward as well, this sling system weakens because those pelvic floor muscles are put on stretch. And then on top of that, we have the baby weight pressing down on them, making them even weaker. And the glutes are getting weak as well because they're all really starting to shorten, like your hamstrings, your glutes. With that forward posture of the pelvis too, we're not activating the glutes as much. So all those things start to affect the way that your pelvic floor muscles work. Here is a diagram of how the pelvic floor muscles and core function. So again, your diaphragm is here at the top, pelvic floor is at the bottom. Every time we take a breath in, what happens is your diaphragm actually flattens out, it pushes all the organs down, and your pelvic floor relaxes. So as we're inhaling, pelvic floor is relaxing. As we're exhaling, pelvic floor needs to activate, it contracts. So that's when like a Kegel occurs, pushes all those organs up, and then your diaphragm goes back to a dome shape. So this is happening all the time on a regular basis. But like I said, with pregnancy, that system does get a bit disturbed. So here's what I had mentioned with that tilt that occurs. There's a lot of hormonal changes, obviously, that we experience when we're pregnant. The ligaments become very lax. There's a lot more movement between the in the joint, sorry, because of the ligament laxity. Joints can become, unstable. There's just more movement in the joints. The uterus is growing. As that uterus is expanding and the baby's growing again, I mentioned earlier that anterior tilt occurs, so that pelvis starts to rock forward. You can see that there's an increase in the curvature of the spine as well, and that's because of, again, all those changes that are pushing us forward as the belly is growing. So there's a lot of load on the pelvic floor. And again, your center of gravity is obviously shifted forward. So all these changes that occur in our bodies due to pregnancy definitely put a strain and increased load on our pelvic floor. So just to kind of show you guys what are those changes that are happening from first onto the third trimester. In the first trimester here, you can see that again, fetus is really small, the uterus is just starting to expand, no major changes, that diaphragm and the pelvic floor are functioning pretty optimally. There's not much load on it. When we get to the second trimester, the baby is starting to grow a bit more. The tilt, I don't know if you can see in this model, but that spine is starting to have an increase, what we call lordotic curve. So that curvature is starting to, in the lower spine is starting to get exaggerated. And that's because the pelvis is starting to rock forward because of the weight of the baby pushing us there. So as there's more weight and that pelvis is being pushed forward, your pelvic floor muscles are actually lengthened a lot. So they're constantly put on stretch, and then there's that load of the baby on them. As there's that load on it, those muscles have a harder time now fully relaxing. They start to get a bit weaker. They start to hold more tone, and that relationship between your diaphragm and your pelvic floor muscle starts to get slightly altered. When we get to the third trimester, obviously the baby's much bigger at that time. The uterus is expanded greatly. Your pelvis is extremely kind of forward at that point. And so what happens is the baby also starts to push up on our diaphragm. So we can't really take nice, deep breaths using the diaphragm. Women will start to have really shallow breathing. They start to breathe up with their upper accessory muscles that we call up here. So more chest breathing as opposed to diaphragm breathing. And so what happens is as the baby's putting pressure on that diaphragm muscle now cannot fully relax. So when the diaphragm has that tightness and that pressure on it and it's not fully relaxing, then obviously the pelvic floor is also not fully relaxing. And because of all that weight on it now and the being pushed so much forward, those muscles aren't able to activate as well. And there's that weakness that happens. And again, that dysfunction between the diaphragm and the pelvic floor. So obviously our goal with pelvic floor therapy is to make sure that we maintain good control and good muscle function of the diaphragm in relation to the pelvic floor, in relation to the deep core muscle, to make sure that even though these changes will naturally occur during pregnancy, they will not disturb the function of that pelvic floor. There won't be a lot of weakness that will occur if we can maintain proper function. And so you won't have any issues. Like our goal is to not have any issues like incontinence, pre and post natal. Maintaining good function throughout pregnancy will allow for a faster recovery of the pelvic floor post-delivery. So recover function of your deep core muscles, maintain glute strength so that the glutes don't get too weak. And then after having baby, it'll take, extra long to get that strength back. So that's kind of some of the changes that we try to stay on top of when we see our patients in clinic. So again, something else that happens, like I mentioned, oops, I'm so sorry. Let me just go back here. Not only is there a lot of pressure and weight being put on the pelvic floor, but there's also a lot of stretch being put on that deep core muscle, the transverse abdominis that I mentioned earlier. Again, everyone will come and, one of their concerns is they don't want to have a diastasis. And I tell all my patients, there is no way to go through a pregnancy without getting a diastasis. We need to have a diastasis because as we're growing the baby, your ab muscles need to separate to allow and accommodate for the growth, expanding uterus and growth of baby. So you can't go through a pregnancy without having any diastasis. It's impossible. However, we educate our patients on how to control the amount of tension they put on what we call the linea alba. So it's this middle portion here that joins to the both abs together. And again, the less we load, and the less tension we put on the linea alba, the less of that separation we're forcing on those abdominal muscles. So we want to allow that natural lengthening in that section, obviously because of growth of baby, but we do not want to put an extra load where we are separating those muscles further. So some risk factors that can make the diastasis slightly worse is what I just kind of mentioned, an increase in intra-abdominal pressure. So lots of holding our breath, straining the core system, straining the pelvic floor. And again, these are things that we teach patients in clinic, how to avoid them, how to breathe properly, how to avoid that increase in intra-abdominal pressure. Repetitive flexion movements such as crunches. Again, we used to kind of scare women, tell them absolutely no crunches. We know better now. Repetitive flexion movements can cause an increase in diastasis only if done inappropriately. So if we do not maintain a good function of our lower abs or TA, we're not connected to them, then repetitive flexion movements can strain the diastasis because we'll only be activating the upper abs and putting a lot more stress and load on the lower abs. However, I have a lot of patients that as we maintain proper good function of the pelvic floor and our lower abdominal deep core muscles, such as the T, they can do some flexion movements. Definitely not towards the end of the pregnancy, but they won't increase that diastasis. So it really is how it's done and the level of function that we maintain on the pelvic floor and the deep core and the deep abdominal muscles. So chronic constipation, usually holding our breath a lot, straining as we're having bowel movements, that will put more load on the abdominal muscles. If you're overweight, obviously that puts more pressure on the abs as well, and the number and the size of babies. So multiple pregnancies, very large babies, like 10 pounds. Yeah, they can put more strain, and genetics, like that's also a very big component. So skin elasticity, how your tissue will respond to deliveries. Like there's been patients that have had with 4 babies and extremely minimal diastasis. So yeah, genetics is also another big component of it. Some of the common pelvic floor dysfunctions during pregnancy, I'll just mention them here, and then we will talk a little bit about them in detail. So the main one obviously is being incontinence. Pelvic floor organ prolapse is another one. Painful intercourse, pelvic girdle pain, pubic symphysis dysfunction. Also, pelvic girdle pain is also referred to as that. Vulvodynia, so lots of pain during the like around the vulva, and vulvar varicosity, so increase diameter and width of the veins near the vulva, so around the labia majora that we will see. And again, they are common, but they are definitely not normal during or after pregnancy. So even though these can happen, we don't want to normalize it and say, oh, this is just a normal part of pregnancy, because obviously there are things that can be done to prevent certain things, but also if a pregnant woman comes in with one of these conditions, there's ways to help her during the pregnancy to make sure that they're not lingering things during the pregnancy and then thereafter. So incontinence. Incontinence is, by definition, any involuntary loss of urine at any time and of any amount. It can be from occasional leaking, like when you have a cough or a sneeze, which is called stress urinary incontinence, because it's an additional stress that's being put on the bladder, and there's weakness in the pelvic floor muscles, so they can't sustain that load, and so then we leak. Or also having an urge to urinate, so it's sudden, it's strong, and oftentimes patients will say they can't make it to the toilet on time. Again, it is incontinence can be quite normal in pregnancy. It is quite normal, but it is quite common, sorry, but it is not to be said that it's a normal part of pregnancy and you just have to, you know, live with it because you're pregnant. So we're going to talk about the risk factors to incontinence. Again, it does happen a little bit more with females. Increased weight through the abdominal, hip area can for sure put you at higher risk. With respect to pregnancy, vaginal deliveries, again, the length of pushing. So did you push for over 2 hours? How much stress was there on that pelvic floor? Was there a lot of perineal trauma, a lot of tearing in the pelvic floor muscles? That will obviously increase the risk because there's more weakness in the pelvic floor muscles. The use of forceps or vacuum will also put more load, more trauma on the pelvic floor, which can cause more weakness. Multiple deliveries, so having multiple babies, 2, 3, 4, doing a lot of high impact activities during pregnancy. So lots of running, lots of jumping. There's not only a load from the baby, but then if we're running, jumping, that's very high impact, can put more stress on the pelvic floor at times when it's getting weak. And chronic coughing can cause some incontinence that puts a lot of additional intra-abdominal pressure and a lot of stress on the pelvic floor. So coughing for weeks and weeks and weeks can definitely cause some urinary incontinence. The second thing that I'm going to talk about is the pelvic organ prolapse. So what this is when the tissue and the muscles of the pelvic floor can no longer support your pelvic floor organs, meaning either the bladder, the uterus, the rectum. And so this results in a bit of a drop of those pelvic organs from their normal resting position. So again, some of the organs that it can occur to is the cervix, the uterus can slightly start to come down, the bladder, the urethra, and the rectum. The common symptoms that patients will experience is a feeling of heaviness around the lower tummy, lower genital area. There's a dragging or a dysfunction, a dragging discomfort, sorry, inside the vagina. Feels like something's coming down into the vaginal canal, vaginal opening, and sometimes, especially with a uterine prolapse, people will feel like they're sitting on a small ball. Feeling or seeing a bulge or a lump coming out of the vagina. So if one of the organs are coming down past that opening, they are worse with standing, prolonged walking. They're better when you're in a lying down position because then the pelvic floor muscles aren't working to support those organs. Again, the main types, out of all of them, the main that we see is a cystocele, which is a prolapsed bladder. It usually occurs from the weakness of that front wall in the pelvic floor that support the bladder. And again, if we think of those changes that are occurring in pregnancy, like we mentioned earlier, that pelvis is rocking forward. There's a lot of stress on the deep core system, a lot of stress on your pelvic floor muscles. And as they get weaker, they just cannot support that bladder, and the bladder can't sit in its resting position as well as it should. There are 4 stages. So a stage 1 is when there's very slight drop, like less than 25% drop of the organs. Stage 2 is around like 25 to 50. Stage 3 is like 50% to 75 drop. And a grade 4 is when one of the organs is just coming out of the vaginal opening. And at that point, even at stage 3 is they're ones that, we want to prevent them from ever getting to that level, obviously, because then women sometimes have to use things such as pessaries, which I'll talk about some treatment options. And again, our goal is to avoid anything kind of occurring into stage 3 and obviously stage 4. The risk factors for it, again, are having more than one kid, like I mentioned with the other ones, larger, like bigger babies, definitely put you at higher risk. There's more strain on the pelvic floor. Oops. I just need to go back here. Forceps or vacuum, there's also more stress on the pelvic floor with that. Increase in intra-abdominal pressure, so chronic bowel straining, lots of constipation, chronic coughing, lots of heavy lifting. Again, that sling system is weakening during pregnancy. And if we do any of the chronic coughing, heavy lifting over and over and over again, that will put more load on the pelvic floor and increase your chances of prolapse from happening. Now, again, people, I know it's very scary. When we have a vaginal delivery, just like the diastasis, though, it is impossible to have no level of a prolapse. There will always be a drop in our organs after having baby because there's a lot of pressure on the pelvic floor with respect to delivering of the baby. So there is definitely a small, we don't test obviously for any prolapse right after childbirth, but even when patients come in 7 weeks postpartum, there still could be a slight descent of those organs. So the goal is to rehab that pelvic floor, strengthen that anterior, strengthen that posterior wall to make sure that all those organs are being held up as best as possible by the pelvic floor muscles. And again, I always tell my patients that, they will never, or after having babies, our organs will never sit up the way they did, when we were 20 or so. But functionally, we can get those muscles to be just as strong and held at a very good level, even though, again, there are some small changes that do occur with where they sit in relation to after having kids. Now, pelvic girdle pain, also known as pubic symphysis dysfunction, super common. We see this a lot in clinic. I do treat this dysfunction just like many other dysfunctions along with massage therapy sometimes, and definitely with chiro. I treat really closely with Dr. Bosner, Dr. Jen as well, is really great with treating patients pre and postpartum. And so what it is a group of symptoms that causes discomfort in the pelvic region. It does affect about 1 out of 5 pregnant women. Can occur at the front and at the back of the pelvis. Very commonly, we see it at the front near the pubic symphysis bone. So the symptoms most often are pain in the front center of the pubic bone, pain in the lower back or on both sides near the what we call sacral lumbar area and sacral iliac joints at the back. Pain in the perineum, so there's pain in the area between the anus and the vagina. The pain will increase with like one-legged standing. So again, putting weight on one leg when you're putting on pants, getting dressed, using stairs, walking, turning over in bed. There's a lot of your adductors attach at the pubic bone. So as we rotate and our legs are shifting to the side, the adductors are activating, and because they attach near the pubic bone, will put more stress in that area, so they increase the pain. They do say, again, it could be due to increased relaxin, sorry, the hormone that happens during pregnancy. The ligaments of the abdomen, hips, pelvis, and the pelvic floor are a lot more relaxed. Also, another common thing is that there's an overguarding of the pelvic floor muscles. We have a tendency to sometimes hold a bit more tension sometimes as women in our pelvic floor, especially when we're pregnant. There's a theory as well, which makes a lot of good sense anatomically, that we always want to kind of protect that belly area when we're pregnant. And so what can happen is we can kind of tense a little bit more, and what we tense is the front pelvic floor muscles that attach on either side of the pubic bone. And so without realizing it, if we're constantly tensing and tensing those muscles, they start to overguard, they become very tight, and because they attach on either side of the pubic bone, that tightness in those muscles puts a lot of pressure there, leading to misalignment of the pelvis. So again, that's where the chiro also comes really handy and very useful. And I find that when patients get physio pelvic floor work along with the chiro, I'll see amazing changes, and almost in a lot of cases, even a relief in pain within 2 weeks of treatment with both myself and chiro. The other thing we'll mention and talk about is the vulvar varicosities. So vulvar varicosities are varicose veins that are at the outer surface of the female genitalia, what we call the vulva. They occur due to an increase in blood volume to the pelvic region during pregnancy. And it's associated, with a decrease on how quickly the blood can flow from the lower body back to your heart. So if there's a lot of tone, tension, I find this also a lot of times in the front anterior muscles of the pelvic floor, and that pumping mechanism in the pelvic floor isn't working as well, that blood flow starts to stay kind of stagnant. There's a lot of fluid in the pelvic area, so that causes a lot of distension and swelling of the veins. Vaginismus is another thing that can occur. It involves a muscle spasm in the pelvic floor muscles. Usually, there's a lot of pain with intercourse. Pardon me, it might be very difficult, might be very painful, especially during insertion. Vulvodynia is chronic pain around the vulva, so the outer area of the near the vaginal opening. So it's described with a sensation of burning, stinging, itchiness, kind of a raw feeling in that area. Extremely sensitive. So any kind of internal exams also not comfortable. So again, those are the main common ones. I mean, there's other things that can also happen with the pelvic floor, but those are the main ones that we see, especially with pregnancy. So how we treat the pelvic floor dysfunctions that we just talked about is, for one, we do an exam. So the way that the exams run is they are usually always an hour long, because of the connection, like I mentioned in the beginning, with the deep core system, the diaphragm, the pelvic floor at the bottom. It's closely connected to hips, glute muscles. So we don't just do the pelvic floor exam. We start off with a global scan of pelvis alignment, standing posture. We look at how the spine moves, how the hips move. We look at pelvic alignment. We look at the core system. So again, diastasis to start off with, if I'm seeing someone earlier on. And then we also do the internal exam. Again, sometimes patients say no to an internal exam, and that's obviously everyone's choice. If an internal exam is not done, we try to cue through the TA and breathing externally. But in order to properly assess those pelvic floor muscles, an internal exam is necessary. So some of the treatments that we use is pelvic floor muscle release if we have really tight muscles. Because again, Kegels are not the answer to pelvic floor dysfunctions. There sometimes could be an over tightening of muscles. So we need to work on releasing them and teaching patients how to let go of their pelvic floor muscles to get that function between the diaphragm and the pelvic floor and deep core system to work optimally. Then we also obviously use pelvic floor muscle training. So we want to regain full strength, full control, get the endurance back of the pelvic floor muscles as well. We train in different positions, whether it be in standing, as patients get into more exercises in 4-point, we will train in those positions as well, and we can check the strength in those positions. Also, we use relaxation techniques, so different yoga poses, core strengthening, glute strengthening, almost always part of my treatment plans with patients. Lots and lots of education. So how to properly breathe, how to reconnect to the diaphragm, pelvic floor, proper lifting techniques, how to get in and out of bed, like the log roll to make sure we don't strain the pelvic floor and the core system to increase the chances of a wider diastasis, and also proper alignment of the pelvis and the spine, which again, more optimal alignment of the spine, the better function of your pelvic floor and in connection to your diaphragm. So oftentimes, again, like I mentioned, Kegels are not always the answer to treatment. They're not always right for everyone, especially in the beginning phases of treatment. Sometimes that's not what's necessary. Some people can leak, and I see this more often than not. There's a lot of leakage due to a tension, a constant tightness in the pelvic floor, never knowing how to let go. So as those muscles, if they stay very tight, I always use sometimes my bicep as an example. If my bicep is always stuck at 90 degrees and I try to pick up like a 5-pound dumbbell, my bicep is only working at 50%, 40% of max force, right? 50% to make it easy. In order for muscles and this is for any muscle in our body, in order for any muscle in our body to work properly, we need that muscle to fully relax, because only then will it be able to have full activation and full contraction. So again, with the pelvic floor, if there is more tension in the pelvic floor, we need to teach patients how to regulate that tension, how to learn how to let go, and then we start working on the strengthening. The pelvic floor therapist can determine, again, if you're doing them correctly. There is a statistic that about 50 to 55% of women are not able to do a proper Kegel. Pardon me. So again, we won't know how well you're doing it. I can gauge externally somewhat how well patients are doing them, but we don't know how all those 3 layers of the pelvic floor are functioning unless we do a pelvic floor exam. The other things that we'll often can use with patients, especially with a lot of pubic symphysis pain, vulvar varicosities, or some pressure in the front abdominal wall, or like belly supports, and some of these slings that that are shown here in the pictures. So belly bands, like in the first picture, they can help alleviate the discomfort and for low back pain, pelvic girdle pain throughout the pregnancy. Again, should be used in moderation. We do not want to rely on wearing these things the whole day, because that will also cause more weakness. The muscles start to rely on these supports. The fit splint, pardon me, is the second picture. It also helps support the back, the belly, the bladder, the hips. Was popular a few years ago. And the third picture is image of the V2 vulvar support. So this is commonly used when there's vulvar varicosities. It can be used before rising in the morning to help prevent excessive swelling of the vulvar veins. So again, if we ever recommend to purchase any one of these things for our patients when they're pregnant, obviously, they'll come in during one of their sessions, and we'll go through how to properly use them, how often, and so on and so forth. The last few things here that we also want to talk about is, and that is part of treatment, is preparing the pelvic floor and going through birth and labor prep. So that's usually, again, patients around 35 weeks will come in. They'll often come in with their partners, so we can review the perineal massage, stretching, relaxation of the pelvic floor muscles, pelvic rocking that we'll start doing if they have an exercise ball at home. We educate them on the different delivery positions. So even at home, when labor begins, the different positions that we can get into to keep that pelvis mobile. We don't want to be just lying on our back. That keeps things locked up, prevents any movement from the sacrum, from occurring, will create more pain during contractions if we're just sitting still and not keeping that pelvis mobile. How to use upright or side-lying positions. We know from multiple years now of research, the side-lying position is considered one of the best positions. The least amount of perineal tearing is shown to occur in that position over and over again. We teach patients, and particularly their partners, hands-on maneuvers that help alleviate some pain during delivery and labor, again, to offload some of the tension between the sacrum and the 2 hip bones. So that's always fun. And again, makes also partners feel very useful, because they actually can help alleviate some of the discomfort that their partners are going through during during the labor, and then also like active labor as well. So some of the takeaway messages, again, urinary incontinence, prolapse, diastasis, they usually can begin with pregnancy and childbirth. But again, they are common, but they're not, should not be considered the norm, and that's just something that you have to live with just because you decided to have a baby and are pregnant. It's important to maintain really good function as best as possible of the pelvic floor, and keep that relationship between the pelvic floor, the diaphragm, the deep core muscles. Kegels are not always the answer to treatment. So again, only by getting a proper assessment of the spine, the hips, the abs, and the pelvic floor, and an internal exam will tell us exactly what the right exercise and the best exercise prescription would be at that point. Avoiding high impact exercises, and again, crunches can be done as long as there's good function and connection to the pelvic floor and the deep core system, like meaning the deep abs. If there is a disconnect, then that's when I would usually say to patients, no, like crunches, not right now, but if we can regain good function with the pelvic floor, the lower abs, they can definitely also be done. We just need to make sure that we're moderating the breathing and we have good control of the mentioned muscles, and then flexion exercises would be totally fine. And again, the only real way to know what the pelvic floor muscles are doing, how to properly retrain them, is through an internal exam. I often get asked when patients should come in to see me. We always say usually after the first trimester. So anytime after like 13, 14 weeks, people can safely start doing pelvic floor treatments. Not that there's any evidence to show that it would be bad in the first trimester. It's just more of a sensitive time period. And so most therapists choose not to do anything in that first trimester. And then usually patients will come back to see us for a reassessment post-delivery after about 6 to 7 weeks after having the baby. So again, if there's any other questions, you can always reach out and email any questions to info@bosnerhealth.com, and just refer them to Adriana, and I'd gladly answer them. So thanks very much. It was a pleasure having this talk today, and hope you guys have a good night.
Thanks so much, Adriana. That was so
Yeah.
supportive and so helpful. And I can't wait to share this replay with our community. And thank you, everyone, for joining us. Have a great night.
Awesome. Bye, guys.
Bye.
Bye.